আসসালামু আলাইকুম। ওয়ার্ল্ড ফ্যামিলি ডক্টর ডে 2021 উপলক্ষে আয়োজিত ওয়েবিনার সিরিজের আজকের সেশনে আপনাদের সবাইকে স্বাগত। গত 19শে মে থেকে 22শে মে 2021 পর্যন্ত এই 4 দিন আমাদের সাথে থাকার জন্য আপনাদের সবাইকে জানাই আন্তরিক ধন্যবাদ। আজকে আমাদের ওয়েবিনার সিরিজের সর্বশেষ অনুষ্ঠান এবং আজকের বিষয় ফ্যামিলি মেডিসিন সার্টিফিকেশন, হাউ এ ইয়ং ফিজিশিয়ান প্রিপেয়ার হিমসেলফ ফর ন্যাশনাল অ্যান্ড ইন্টারন্যাশনাল এরিনা অ্যাজ আ ফ্যামিলি ডক্টর। আশা করি আজকের এই সুন্দর এবং গুরুত্বপূর্ণ আলোচনা সবার ভালো লাগবে এবং বিশেষ করে ইয়ং ডক্টরদেরকে ফ্যামিলি মেডিসিন বিষয়ে জানার, ক্যারিয়ার করার আগ্রহ করে তুলবে। আমি ডাক্তার সালেহ আহমেদ, আজকের এই ওয়েবিনার সিরিজে প্রোগ্রামের মডারেটর। সবাইকে আরও একবার স্বাগত জানাচ্ছি আজকের এই প্রোগ্রামে। ওয়েবিনার শুরু করার আগেই আমি জানাতে চাচ্ছি এই প্রোগ্রাম রেকর্ডেড হচ্ছে এবং তা সরাসরি প্ল্যাটফর্মের ফেসবুক পেজ অ্যান্ড H1 চ্যানেলে লাইভ প্রদর্শিত হচ্ছে। পরবর্তীতে অন্যান্য সামাজিক মাধ্যমেও তা শেয়ার করা হবে, তাই দয়া করে সবাইকে ভিডিও অন করে রাখার অনুরোধ করছি। আপনার কম্পিউটার সাউন্ড সিস্টেম ঠিক আছে কিনা তা যাচাই করে দেখুন। প্রেজেন্টেশনের সময় সবাইকে অনুরোধ করছি সাউন্ড মিউট করে রাখা। আপনার কথা বলার প্রয়োজন হলে আনমিউট করে কথা বলতে পারবেন। আমি প্রয়োজনে সবাইকে মিউট করে রাখতে পারি। যদি কোনো প্রশ্ন থাকে প্রেজেন্টেশনের পরে তা করতে পারবেন। প্রশ্ন উত্তর সেশনের জন্য আমাদের একটি নির্দিষ্ট সেকশন থাকে। তাহলে আর দেরি না করে আমরা আমাদের ওয়েবিনার শুরু করতে যাচ্ছি। আজকের বিষয় ফ্যামিলি মেডিসিন সার্টিফিকেশন, হাউ এ ইয়ং ফিজিশিয়ান ক্যান প্রিপেয়ার হিমসেলফ ফর ন্যাশনাল অ্যান্ড ইন্টারন্যাশনাল এরিনা অ্যাজ এ ফ্যামিলি ডক্টর। এই বিষয়ে আলোচনা করার জন্য আমাদের মাঝে আসছেন ডাক্তার এম ওসমান গনি। ডাক্তার ওসমান গনি একজন মেধাবী চিকিৎসক হিসাবে বর্তমানে অ্যাসোসিয়েট প্রফেসর, ঢাকা সেন্ট্রাল ইন্টারন্যাশনাল মেডিকেল কলেজে মেডিসিন বিভাগে কর্মরত আছেন। উনি এমআরসি জিপি ইন্টারন্যাশনাল, এমআরসিপি ইউকে ডিগ্রি অর্জন করেছেন। তিনি অনেকদিন ধরে বাংলাদেশে ফ্যামিলি মেডিসিন সাবজেক্টে উন্নতির পিছনে কারিগর হিসাবে আছেন। নিজেও অনেকদিন ফ্যামিলি মেডিসিন বিভাগে দেশে এবং দেশের বাইরে কাজ করেছেন। স্যার, আপনাকে ধন্যবাদ আমাদের সাথে আজকে ওয়েবিনারে যোগ দেওয়ার জন্য। এখন আমি অনুরোধ করছি ডাক্তার ওসমান গনি স্যারকে তার প্রেজেন্টেশনটা শুরু করার জন্য।
Thank you, Honorable Moderator Dr. Saleh, and my respect to respectable teachers today, and a gratitude to platform to give and offer me a venue to discuss something which will be actually exerted from the heart. And I think that this is my privilege to say something on family medicine, and especially targeting the young doctors. And I'm not too much mature enough, and all of here are too much senior to me and my respectable teachers as well. So with my due respect to everyone and welcome to all of the participants and the audiences, I like to proceed on. And in addition, I like to inform you that recently I'm working as academic coordinator in the platform family medicine wing as well. So welcome you, and I'm just being on to my presentation now. And my topic already you have heard, the family medicine certification, how a young physician can prepare himself for national and international arenas as a family doctor. And I will confine my discussion within this as much as possible. In the later part of my discussion, I will highlight what could be the characteristics of a physician, especially I'm not meaning all the doctors of all specialties, especially those who will be physicians. They should have some qualities, and I will try my best to address this issue at the later part of my discussion. First thing is that to initiate the talk, if we ask, or anybody ask anyone, what is the first door a patient knocks in our society, in our clinical practice? And most of us having the answer is not very pleasurable answer, in my sense. The people are easily getting a person, most of the time, not a qualified person. most of the time they are quack. We rather unfortunately say them quacks. They are not actually a graduated medical person, but they have a lot of experience of dealing the person. I am meaning they have a lot of experience of dealing a person, not a patient. But what is expected in this field? A person should get easily access to a doctor. So why our people cannot get access to a doctor is a matter of big discussion, actually. I don't like to address there, but the unfortunate thing is that we are the doctor nowadays not much in touch with the population or the patients and the people. So the topic, the family medicine, actually, how it comes out. It is not a very new thing, not new phenomena. Rather, it could be a thought of very old thing in a new format, what we are discussing for last few days, and today will be the last day. I believe that my discussion will be helpful for all of you to understand this thing. And what was our dream? Definitely, our parents as well as ourselves, we will be a doctor. Doctor means mostly we will be a physician. We will be in touch of the patient. We will serve the humanity. The reason is that our belief was that doctor is next to the God. It's a great feeling actually we try to achieve. But what is our situation in current days? Not too much pleasurable and too much appreciating. Anyway, to create the doctor, what we are thinking, a doctor will be a tomorrow's doctor. What will be the structure of learning? What will be the curriculum of tomorrow's doctor? And what doctor expect from our curriculum or the structure study, even in the undergraduate life? Mostly I mean the undergraduate life, we don't know really. The expectation is varied, though we told that we like to be a physician, the expectation being changed day by day in course of time. And what is nation expecting? Definitely the service, no doubt. But very unfortunate thing is that what doctor can contribute is not uniform one, is not very confident one. The lack of skill, lack of understanding, and lack of the experience as well as the qualities, how to interact with the patient, how to communicate, big gaps are there. So the expectation of the nation is not being fulfilled, and the expectation of a doctor also being jeopardized in course of his lifetime or education life. So what is the picture of a tomorrow's doctor is not much clear cut to us. Why this failure happened is very simple. If we think of this, the planning in everywhere, any target, any goal, planning is very important. And then the second one is implementation. There is a lot of discussion about the criticism of the planning of our education. Even then, more or less, our senior teachers' expertise, they develop a planning for the education. But the more the bad thing happens in implementation, implementation needs a very big logistic supports as well as very good, efficient manpower, which is definitely lacking in our country. And there is very variations of our medical education institutions. If I like to say very simply, the difference between education of the government medical colleges and the private medical colleges, far differences are there. Those who worked before in the government medical college and in the private medical college nowadays, they can understand very practically what is the difference there. So I like to say in our Bangla proverb that many things actually are written, many things are available, but problem is in the implementation. Like to say that Kajir Guru ketabe ache, goale dai. I don't know, many of you, my honorable teachers today, will you agree with me or not? This is my understanding, just it's my privilege to share with you all. And after the graduation, our young doctors are feeling the problem. Nowadays, you have seen that the stigma, what is that? They are stigmatized, rather to say, to be labeled as simple MBBS. Why it happens so? Why we added this simple word to a graduate doctor there? you see that the MBBS is the graduation of not only one subject. This is the graduation of medicine as well as surgery. But if frustration is roaring, frustration is prevailing, especially in our young doctors. The reason is that, again, I like to mention that they are actually not grown as an efficient doctor of tomorrow. Again, many factors, many responsibilities are there. Unfortunately, it is happening. So I am again not to go inside of these, but just is a superficial observation. And for that, what they are thinking now, they are now actually always thinking that to achieve a big career in medicine, surgery, or any other subjects. So there are some of the doctors, I'm not meaning the some, a significant number of young doctors are searching a job, a qualification as to be a government officer. Okay, that's good. And some are actually now moving to achieve the fellowship, membership, or even in the Western achievement for the MRCP and other allied degrees are there, or diplomas. But how long it will take? Definitely 4 5 months, 4 5 years, sometimes 7 to 8 years. So what they will do in the meantime, and how much tolerable to sustain this strength or the labor, the capability, not only physically, rather financially as well. So there is a big gap happen after graduation as well as to achieve a career. But what nation wants? A doctor will be a graduate doctor, will be efficient enough to serve the nations of the people of the country. So now what the young doctors are doing, they're searching a job in corporate hospital just to overcome the feelings of simple MBBS or a social, what I say, identification. They are actually hunger for social identification as well. And few doctors searching a job, not the job I mean, to have a space to sit in many of the medicine shops. I'm meaning the doctors who are actually thinking to be a physician. So I like to highlight here that the doctors are having the desire to be a physician from the very beginning. But is it the real space for them? If we ask them, if we ask each other also, is the corporate hospital is the actual place of them? Is it not the place of career development as well? And practice in the medicine shop rather is not the actual site of a doctor, actual place of a doctor. So somehow they are existing many years and they are fighting for achieving these degrees and others. Anyway, so what they will do and what we can offer to them, what nation actually expecting for us in our nation and throughout the world as well. So we need many, many specialists in many subjects, no doubt. If we consider the situation of our nation, what we need in everywhere actually we need as in this financial socio-economic status of a country, we need the jack of all trades. So there is a criticism also, somebody will say that if who will be a jack of all trades, actually he will be a master of none. So what? If jack of all trades can cover most of the works of the nation, that's enough. What are the health problems? What are common health problems, preventable health problems? Is it very tertiary level service? It's no. It's very, very primary health problems actually prevailing in our country. Most of them are preventable. The death rate of the diseases from primary health care is significant, actually not in the terminal events, but we are very, very indulgent with very advanced treatment facilities. We don't like to discourage these, but I like to highlight that we need the tomorrow's doctor to be jack of all trades. This is my feelings. I'm just my humble privilege to share with you today. Just we look back before the advent of specialization and the super specialization, even a few decades before, what we are getting the treatment from our father, our grandfather in their ages. A single doctor used to take care of the different categories of diseases. Later on, the specialization actually took the place. The specialist is everything at all. Sometimes specialists become frustrated if the clinical situation is beyond his domain. And what specialists used to do, specialists try to refer the cases to some other specialist. But I'm thinking that how much it is practicable for the common diseases, common health issues, the specialist will refer to other specialists. How the poor people of our country can tolerate this, rather to say have the financial burden. Socially unprivileged people cannot move here and there. So it means that we need a jack of trade actually in our medical fields. We like to remind you simply in our previous knowledge, World Health Organization definition of the health. And you know that this is the state of complete physical, mental, social, and somewhere spiritual well-being. What our doctors are doing, the main focus, the physical or biological, we are diagnosing the disease, giving the treatment. But if we completely give the health service to the population, we have to address all the parameters, physical, mental, social, and spiritual some of the time. But we are very ignorant in the mental issue, especially the social issue, much ignorant topic. So what we are doing nowadays in last 1 decade or 2 decades, we are focusing this physical issue of the people, not focusing this thing. So actually, we are not providing the health service at all, in my sense. So in the family medicine, if we tell about the diagnostic approach, the approach minimum 3, the physical or biological diagnosis, mental or psychological diagnosis, and the social diagnosis. The problem of the society of a person, society, I mean including his family as well. So if you combine these parameters to serve a people or the patient, then there will be chance of ensuring the maximum health service to the person and even to the family. So just to touch this thing, I like to highlight, with due respect to all of the specialists, those who are practicing our country, there may be similarities in the practice of family medicine and the internist. But what are the differences here? In very short, if I like to say that the internist most of the time treats the adult populations of the patient. Their expertise, no doubt, in internal medicine, but the general practitioners are trained enough to provide the care for all patients of all ages, all diseases they are dealing, and all the dimensions of the disease. Dimensions of the health or disease, whatever we say, everything covered by a general practitioner's training. But it doesn't mean that general practitioner will cover in the extreme level of the management of the patient, but the spectrum in the bottom line, the role of the family medicine is unparalleled, I like to say. As some differentiation in general practitioners and the specialist, I'm not detailing from here, just to say there's some keywords from here. The GP's duty mainly to exclude the serious diseases, but the specialists are confirming the disease and giving the treatment. GP tolerate uncertainty, but specialists reduce uncertainty. A GP explore probability, seeing patients from a population with a relatively low incidence of serious disease, but specialists explore possibility, seeing a pre-selected population of patients with a relatively high incidence of serious disease. GP marginalize the danger, but specialists marginalize error. So these themes should be in the mind of a GP, and we can proceed further as specialist. And it is very true that the family medicine established as a specialty in abroad mostly, and we are trying our best to actually establish the family medicine as a specialist subject in our country. And last few years, our beloved, some seniors, honorable colleagues are moving day and night here, door to door also. And we are now some relatively younger doctors and the teachers also, we are with them, because we need jack of all trade. But what is the subject of a specialty here? Suppose somebody is cardiologist, somebody nephrologist. So how can we label the subject of our specialty of the family medicine? If you say, okay, this is family medicine, what about if you tell to somebody that family medicine, you are family doctor, oh, you are treating the members of the family, and somebody recognized us sometime that, oh, he's my friend, he's my family doctor. That means over telephone, they can get access to me, and I can give some suggestion of paracetamol and histamine and other. The concept actually limited up to there. But in my previous a little small discussion, comparing or considering the different parameters of the health and disease, if I said a word that the family medicine could be the patient specialist, it is not the specialist of a specific disease. I don't know, it will be pleasurable to hear to my senior teachers and others as well. It's my only feelings that family medicine could be specialist of a patient. This is the actually real message of holistic approach to the patient. And this is not only from mine, and came out from not my mind. If you see the quote, the great physician in this world, William Osler, you know, what he said, the good physician treats the disease. The great physician treats the patient who has the disease. I think it is self-explanatory to be a physician of a patient, not only of a disease. So in the world, in the international perspective, the family medicine is very established subject one. I will take 1 minute time, a privilege, just to show the McGill University profile of the doctors or the teacher working there. Just I'm browsing the internet now. I think you can visible. It's visible to you. So just you see that how bright and smiley faces are there. The big list are there. They have the career of professor, associate professor, or assistant professor in family medicine. So the big list, I'm just scrolling up, and there is another list also. So many doctors in the world now actually establish the subject as family medicine, and in our actually our country, we are trying our best to do, and one great man in the current time, with our respect, you know many of him, the Professor John Murtha. He's the author of very popular book in the family medicine. So a very little touch in few seconds, I tried my best to show you how the family medicine is established in the world. But all the subjects to develop the specialty needs training. And what is the scope in our country now, or scope in the abroad a little bit? My next talk will be on this. I like to inform you, and many of you know that the institutions of the family medicine in our country in Bangladesh, the Bangladesh College of General Practitioners, they are providing the qualifications of the fellowship of the College of General Practitioners, and Bangladesh Academy of the Family Physician, they are providing the diploma. And the great institution in our country, the leader of our medical education, the Bangladesh College of Physicians and Surgeons, they are providing MCPS and the FCPS in the family medicine from many years before. These are our native qualifications, but very interestingly, one international qualifications available in our country from many years back. I can remember maybe more than a decade, the Royal College of General Practitioner UK conducting AMRCGP international examination by South Asian Board. So scopes are though not too much, but scopes are available. Those my beloved young doctors who you want to develop your career, minimum you can avail these opportunities. Though unfortunately, we like to say that until many years over, still we like to say that one of our senior colleagues today, our honorable panelist also, he was designated as the only one FCPS in family medicine. It's not very fortunate thing happened to us. The reason is that actually we couldn't disseminate the message. We couldn't prove ourselves as efficient physician or efficient teacher in the field of family medicine. So this is the time now to see forward, to prove ourselves that family medicine could be a specialty, and family medicine can handle most of the common health issues in the nation. So these are the institutions, especially academic institutions, and whatever the practice center, very few, and not actually mentioning is possible that we have many institutions, but in last few years, it is our, rather to say, the pride in the family medicine, one private sector came forward. Many of you know that Prava Health, they tried their best to uplift the honor of the family practice, to send the messages. And in the last COVID situation, they have done a lot. And they definitely proved themselves that they are an efficient institution in the family medicine sector. And we came to know that in last 3-day sessions also, and senior colleagues also, and the chief medical officer also was in our sessions. And from her verses, we understand that they will do something great in our country. We hope that, and best wishes for them as well. So in the summary, actually, though we have many institutions and one special center, but it needs some the work plan and organized effort for further flourishment, and we are dreaming so. Internationally, definitely there's growing demand in the comprehensive health care. And if I say that there are some very first world advanced countries, I have shown one example of McGill University of Australia. And what about other countries, especially the Middle East also? I like to say something about that a little now. Even then, just little touch that even the MRCGP available in our country to enrich our career, though the MRCGP International designed their curriculum for the doctors working outside UK, but they are giving the extra credit for having the MRCGP, especially in the Australia and the Canada as a family physician. And very important for the Gulf countries, those who work in Gulf countries, I have some experience to work there. And nowadays, what they are thinking that all the doctors in the primary care management will have definitely a basis in the family medicine. They are appreciating now the careers in family medicine. Even those doctors not having the orientation in the family medicine, they are providing this orientation. And the last recent 1 or 2 years, it happened that those who are not having career in family medicine, they are not renewing their license of medical practice there. And last of all, those who work in outside country of the Bangladesh, you know that all the license examination is based on the topics of family medicine mostly. And personally, I have the experience as well. So family medicine, not only important for serving the people academically also, it is very important. And this is a letter actually sent to us from the colleagues from KSA. The MRCGP International, they are giving the recognition of equivalent for any of the membership of the Royal Colleges. So it is a very good news for the career seeker colleagues, those who are attending today and those who will hear us in a later date. So it's very encouraging. And many of you have seen these bright faces. And we are proud that the Dr. Farzana Hussain working as GP in the UK, and the billboard was set up there to honor her. So definitely, as General Practitioner, it is very good news for us, and we salute her as a Bangladeshi doctor. Now I like to highlight the clinician's skill or characteristics, what a clinician should have. A clinician must have 7 skills. If we say one by one, first of all, the physical examination skill. Second, identifying the physical sign. Third is the clinical communications. 4, differential diagnosis. 5, clinical judgment. 6, managing patient concerns, and the 7th one is the maintaining patient welfare. So it is a big chapter. Actually, I don't like to highlight more, but I like to share my opinion, and most of my senior teachers and others will agree that we are very poor in clinical communications. And the clinical communications actually guides us to be a good consultant. So we must develop our capability of the consultancy as well as the communication. And patient concern is very important. We are ignoring, for example, what patient is thinking about his illness. We are actually ignoring this. It is called the paternalistic approach in the consultation, or dictator-like approach in the consultation. Actually, what is the patient to us? Patient is expert in his feelings, in his symptomatology, in his expression. So in the consultation of the concept, I like to say, and it is not my thinking actually, the concept actually driven by the Royal College of General Practitioners. This is the meeting of two experts and the interaction between two complicated and differently motivated human beings. So all are equal. We are the doctor, he is the patient. So doctor should develop in the skill of 23 principles. I'm just showing to you now. I am not here to detail, to explain each and everything. These 23 principles or qualities doctor should have during consultation. But I'm here just to highlight few words, few points. In the red box you can see now. We don't know how to ask a question to the patient most of the time. Why we don't know? I apologize to all of us, to seniors and expertise. Many of you know it, but the experience, few years as a teacher in undergraduate students and some postgraduate levels also, we don't know what is the meaning of open question, what is the meaning of closed question, what is the meaning of probing question. So a lot of things are there in consultation skills, and we are using the jargon to the population. And those who come across the family medicine exams, even in the home and abroad, all of us know that the jargon is very, very prohibited in the exam as well. I'm not meaning in the family medicine, even in our degree achievement or other examination also. The jargon is too much sensitive issues because patient will not understand how to choose a word. It is very, very important. So there are 4 or 5 points I have highlighted. These are very, very ignorant in our consultation. So overall, a consultant or a doctor or a physician should have the capabilities or the skill in 23 principle, no doubt. And I think that when we could be able to establish the family medicine in our country, in our young doctors, we will try our best to develop all of these 23 qualities. And the lackings of undergraduate education, and we cannot actually touch it. We cannot solve the problem over day and night. Everybody we are telling in many social medias and many speeches and anywhere in many settings, is the problem is very big. There should be the what I say a joint effort from the private and the public sector. So it's a very big issue. But thing will be that what is gone is gone. What has happened is happened. Now the time to develop, to create many jack of all trades in our country by in the context of family medicine, and it is possible, So doctor is to actually be oriented what is rolling in the mind of the patient, and a family doctor definitely will answer every question of the patient. These 4 or 5 things, we are very oriented to say the name of the disease and others. We know everything, but what we say to the patient in our communication. If I give some example in few seconds, and when we ask our patients, when I see the patient in follow-up, that do you know what is the name of your disease? Most of the patient told that, doctor, sorry, I don't know the name of my disease. So did your previous physician tell you that the name of your disease, or did you ask him or her? Yes, I asked my previous physician. What was the answer? Okay, you take the medicine and you will be okay. It's just bypassing. Actually, we are not answering the questions of the patient. But thing is that how much we are capable to answer all of the questions. So these are some examples of traditional the questions of the patient. We have to be very ready for this and to answer all of the questions. I just picked up some examples. The list may be more and more. The red marks are actually for the spouse. This is the male-female issue, especially in the last 3-1 or the 2-1, especially for the female patient. And in our traditional learning, in the curriculum or the topics we are teaching about a disease in the medical colleges, actually the topics are what I say, that's ignored issue, and we are not giving more emphasis on these. We are giving some discussion of the disease, how to investigate the case, and how to manage the patient. Manage means to give some medicine and to treat the patient surgically. So these are the main things. We are giving the depth. We are not touching the mind of a patient. So anyway, after achieving the qualities of a family physician, we have to have the process of re-evaluation, because the 4 components are very important to assess the physician characteristics. These are the professionalism, self-assessment, and lifelong learning, cognitive expertise, performance improvement. So the family medicine certificate, what we are planning, actually is a matter of recertification, and this certification definitely a requirement to practice as family physician. I don't like to mean that it could be a career of diploma or a degree in the family medicine like MRCP UK or MRCGP international or any other, or the fellowship in the available degree and diploma in our country. But a certificate program could have in a very short-term plan. And we know that in our country, especially the Burdom developed their certificate program of diabetology. You know that CCD, the certificate course of the diabetology, and well accepted topic. One word I like to say to you that SIG means a special interest group. Nowadays, throughout the world, there are some special interest group developed in the doctor community to develop the skill, learning, and everything in a specific disease. Especially, they are serving the people having such diseases. This is one of the area of clinical practice, no doubt. But without certificate, we cannot practice. Somebody is to give the certificate, and somebody is to accept the certificate, because the certificate as a requirement which will encourage clinical excellence and the benefits the both physician and the patient as well. But who can provide certificate? Is it anyone? Yes, anyone can provide a certificate. But thing is that an organized institution is better to offer a certificate. But again, the matter of recognition of the certificate, to whom it is shown. So we can give a certificate. We have to do sometime the letter of introduction of specific doctors to work somewhere else. Sometime somebody can gather with many students and others to give 3 or 4 days courses, and they can provide certificate. But thing is that, is it how much valid? And thank you very much, my honorable teachers and our participants who audienced me very patiently. Thank you.